My name is Evandro Azambuja, a medical oncologist from the Jules Bordet Institute in Brussels, Belgium, and it's my pleasure to be here today in San Antonio Breast Cancer Symposium 2022 to discuss with you some findings in hormone receptor positive HER2 negative breast cancer. I'm going to start with the updated results of the TAILORx trial. This randomized trial looked for patients with early breast cancer, hormone receptor positive, HER2 negative, and lymph node negative. Those patients were tested with Oncotype DX, and if they had a score less than 11, the patients received endocrine therapy alone. If the score was greater than 25, this patient would receive chemotherapy. And if the score was between 11 and 25, those patients were randomized to receive chemoendocrine therapy or endocrine therapy alone. The endpoint was to decrease the chemotherapy in those patients to see who are the patients who really need chemotherapy. Primary results have been already presented in two different occasions, and now the updated results at 12 years. What they showed, they could conclude that patients with hormone receptor positive, HER2 negative, lymph node negative disease, and score between 11 and 25 from Oncotype, those patients, they do not require chemotherapy in the entire population. They also looked into the population that is postmenopausal. Those patients, we can clearly say that they do not require chemotherapy, so we do not need to give chemotherapy to those patients. Endocrine therapy as adjuvant treatment is enough. The problem remains for patients who are premenopausal and have a low score between 11 and 25. This patient population, we cannot exclude a benefit of chemotherapy, and we don't know whether this is because the chemotherapy per se or is because the ovarian function suppression due to chemotherapy. So what they looked in the population between 46 and 50 years old, premenopausal, those patients with a score 21 to 25, they had a big benefit of chemotherapy. Patients with a score between 11 and 16 had less benefit. So I think that patients who are premenopausal, young patients 46 to 50, if they have a score between 21 and 25, you should discuss chemotherapy with those patients. The scores between 11 and 16, we can discuss just endocrine therapy and ovarian function suppression for those patients. I think this was the main conclusion of the TAILORx. I'm going to switch now for another strategy that use the CDK4/6 inhibitors in breast cancer patients. I'm going to start with the new data of the Monarch E trial, which is the trial looking for a high-risk patient population, hormone receptor positive, HER2 negative, but high risk of relapse, positive lymph nodes or features like grade 3, high score index. So high risk of relapse. Those patients, they have been randomized to receive endocrine therapy alone or endocrine therapy plus abemaciclib for 2 years. The trial has already presented results in 2 occasions as well, and now they present the results with a longer follow-up, and there was an analysis of overall survival that was triggered by 18 months after the primary endpoint was presented. And what they could show, they confirmed once more the abemaciclib in this high-risk patient population. They decreased the risk of invasive disease-free survival about 6.8%. They decreased the risk of a distant relapse by almost 6%, so confirming the previous findings. They look into overall survival, but at this moment is still immature. We have to follow up those patients for a long period of time to see whether the abemaciclib is going to translate into overall survival as well. But again, it's very reassuring for patients. Abemaciclib for 2 years in patients with a high risk of relapse improves invasive disease-free survival, improves distant relapse-free survival, and overall survival is still immature. There is a tendency to go to better overall survival, but we have to wait their final results. Focus is still in the CDK4/6 inhibitors. There was a very interesting trial looking a randomized trial, few patients, 222 patients with a very high risk visceral disease, decrease visceral in 50% of those patients, first-line treatment. So those patients, normally you would give chemotherapy to them because they have a lot of visceral disease. But this trial was very ambitious, and they compare endocrine therapy plus ribociclib versus chemotherapy. In this case, combination of chemotherapy, two agents. What they looked at, they found that if you use endocrine therapy, CDK4/6 inhibitors, you do not need to give chemotherapy as first line to those patients. We improve outcomes, we improve progression-free survival, we see a better overall survival in those patients. It's still immature, but the progression-free survival is much better. So once more, we have to think not necessarily metastatic disease with a high tumor burden, we need to start with chemotherapy. This challenges the concept of visceral crisis as well, but it's very interesting showing that endocrine therapy, CDK4/6 inhibitors, in this case ribociclib, can improve outcomes of patients compared to chemotherapy. One important message for patients, not because of metastatic disease, they do not require chemotherapy frontline, once more confirming our theory. And the last study that I would like to discuss with you was some results of the TROPiCS-02. This trial looking for hormone receptor positive HER2 negative patients who were metastatic. They received a median of 3 lines of therapy, and those patients were randomized to receive sacituzumab versus chemotherapy as per physician's choice. So this trial already presented results in 2 occasions as well. First, it improves progression-free survival, was a modest improvement by 1.5 months. It improves overall survival by 3.2 months, both statistically significant. And now what they looked is according to TROP2. TROP2, sacituzumab blocks the TROP2, and TROP2 is expressed in about 80 to 90% of all breast cancers. What they looked is whether the amount of expression of TROP2 would predict the response to sacituzumab govitecan in hormone receptor positive HER2 negative in the TROPiCS-02 trial. So they looked at different cohorts, greater than 100, between 10 and 100, and less than 10. And what we can see, sacituzumab govitecan benefit all patients independent of the expression of the TROP2. So this shows that this is not a marker that could be used to predict the response to sacituzumab govitecan. I think this is very important. This was also shown in the triple-negative breast cancer population. TROP2 should not be used to decide who are the patients who are going to use sacituzumab govitecan. Sacituzumab govitecan is beneficial independent of the states of TROP2. So I think this was the main summary of this HER2 negative hormone receptor positive sessions that I had today, and thank you very much.